So our brains and physiology talk to each other, and they've come to the decision that once our hormones go, we better put some stores in. Yeah. So they put it all around our abdominal organs.
Hi, I'm Jo Clark, and thanks so much for joining me today. This is the Redefining Midlife podcast, a podcast designed for the 40-plus woman who is determined to challenge society's myths and beliefs around midlife. It's for the woman who is inspired and ready to define midlife her way. Join me each week as I chat to health and wellness experts for up-to-date information on how to live well as some special conversations with incredible everyday women redefining what midlife can look like. Here's to making our next half of life even better than the first. Welcome to episode 119 of the Redefining Midlife podcast and our last episode of 2024. I'll be back with some more fabulous guests and topics in the new year, so during this short break of mine, just catch up on any episodes that you may have missed. Now, in this episode, I'm welcoming back Dr. Sian Hebron, who happens to be my personal women's health doctor. Now, Dr. Sian featured in episode 105, so if you haven't heard that one, just make sure that you listen back to that one also, because it is chock-a-block full of information that all women should know about. Now, there's so much for us to learn and to be informed about when it comes to midlife women's health, because this is an area that has been neglected by research for so long, despite women being over 50% of the population. And if living well for longer is a goal of yours, like it is for me, then listen in as Dr. Sian shares some of the cutting-edge research findings that she heard from the recent World Menopause Summit in Melbourne. And we also chat about one of the most frustrating and triggering symptoms of menopause and getting older. It's that unwanted weight gain that appears in a blink but refuses to disappear in a hurry. Now, we did plan to answer more listener questions, but the time raced by and Dr. Sian had patients to see. Now, I'll be having Dr. Sian back on the show in the new year, so we can cover those questions then. Bringing you important health information is something I'm so passionate about, because every single woman deserves to be informed and be empowered on how to best care for her body and her health. So in return of this information that I give to you, I'd just love for you to share this episode with another woman that you know. And if you could also just take a quick moment to rate and review the show. That helps to get the algorithm working, and it means that other midlife women will find this podcast. Now, if there's any other menopause or midlife health topic that you'd like us to cover in a future episode, or if you've got a question you'd like Dr. Sian to answer for you, just message me on Instagram or send an email to me at jo@joclarkcoaching.com. Now, on to today's show. A very big welcome back to the podcast, Dr. Sian.
Thank you so much, Jo, for asking me back. I'm very thrilled to be here, chatting to you again.
Listeners loved the first time we had with you on the podcast, so I'm absolutely thrilled that you're back again for a second episode.
Aren't they kind?
Our last episode was back in September of this year,
yes,
which is 2024, and I'm keen to have you back on the show just so you can update, all of the wonderful listeners on some of the important topics that surround women's health, particularly in the middle of life and beyond. So some of the topics and research and conversations that you learned and you were a part of when you recently went to the World Menopause Congress that was held in Melbourne in Australia. And also there are endless topics that we could talk about with regards to women's health. But today I've chosen one which is weight gain. And that's a really unwelcome symptom that many women experience in the middle of life, including myself. And to finish off our conversation today, I've also got a number of listener questions that we didn't get to last time. So on a personal note for you, how was the World Congress on Menopause and what did you learn from that?
The Congress was extraordinary. They started at 7:30 in the morning and didn't finish till about the same time in the evening. And there was such a number of different sessions that you could go to. You couldn't get to all of them, even if you wanted to. And Fortunately, they recorded them, which has been great. So the ones that you couldn't get to, we've been able to watch online, which has been amazing. It was a great atmosphere. There were people from all over the world, literally all over the world, and all coming together, all with a common interest in women's health and trying to, gather as much evidence and research together in one place to be discussed by, women like myself, who are at the battle lines, if you like, and all the researchers from around the world having that ability to come together and share the research that they're doing. I suppose for me, the standouts were, number one, cardiovascular health in women. It's something that we all know about, that women do have heart disease as they get older, but how different we are to the men was really much presented in the symposiums and plenary lectures that they gave. We're not mini men, but most of the research into cardiovascular health has obviously been mainly studied on men. In fact, one of the professors from London quipped that, when he talks to his cardiology friends about estrogen, they say, "What's that?" And, and he even quipped that they may even struggle to know what a woman was.
Oh, that's right.
So you can see that we, for many years, women have not been the centre of attention in health studies and education for doctors even. And fortunately, that is changing. And there was a lot of up-to-date research that was presented. I suppose for me, the take-homes were, and when I'm discussing with women about cardiovascular health, is one, yes, we're not mini men. Stop comparing us. Two, estrogen is protective to us, so that before we lag sort of 10 years behind men as far as the risk and rate of cardiovascular events. As soon as we lose our estrogen, we rapidly catch up. And what estrogen is capable of doing to our arteries that supply our heart, the blood that it needs to work, is that estrogen protects the lining of the heart vessels from cholesterol being deposited, causing plaques that block the arteries. And that's what a heart attack is. It's a blocked heart artery. Yeah. It also dilates the blood vessels, so we get better blood flow that way. So when our estrogen is removed, there's this sort of fairly rapid change in the blood vessels that supply our heart. Now, remembering that blood vessels also supply our brain, our kidneys, our legs, every part of us. But, for the sake of discussion, we'll just talk about heart events. So when they questioned women, what are you most afraid of dying from? Most women say breast cancer or cancer in general. But when there was a presentation where she pointed out that really only 4% of women will die from breast cancer, 10 times as many, 40%, will succumb to some form of cardiovascular disease. Yeah,
Extraordinary.
That is extraordinary. How many women actually think I am at risk of having a heart attack? I don't think many of us do. I don't think it comes on our agenda, because we've always seen images of men clutching their hearts and collapsing in media, in our lives, really. It's the men who have the heart attacks. Women don't have heart attacks. Anyway, so the other thing they pointed out is that often women are misdiagnosed with heart disease. So they're missed because we present in different ways. We aren't presenting with the classic clutch to the chest, drop to the ground. We have vague symptoms, breathlessness, changing heart rate when we exercise more than we did before, vague chest discomfort, nausea. So we don't present in the same way. And even if we do go to hospital, often it's not considered as a diagnosis. Or you're having a panic attack, or you've got heartburn, must be musculoskeletal. I think it's changing, but that often happens, and I have unfortunately had patients where that's happened to. So knowing that, they also realise that a lot of women, even after a cardiovascular event, are not getting standardised treatment that we know works for some reason. I don't know why they weren't able to explain that, but they were saying often women weren't treated in the same way as men post cardiac event. They're more likely to go on and have another event or die. Yeah. So what that taught me as a health professional is you need to have this conversation. You need to, with every woman who comes in, probably past the age of 35, start talking to them about their heart risk. Yeah. And there are some really good online tools that GPs can use, and even people can choose to use. If you go on and do cardiovascular risk assessment, there are these little drop-down boxes that you can fill in. You do need to know what your blood pressure and your cholesterol level is, but also, family history. Did you smoke? If you had diabetes? And that will give you what the chances are of you having a heart attack in the next 5 to 10 years. It will give you a risk calculation. And if you're in that moderate risk, well, you better get a move on and start doing something about it. Yeah. If you're in low risk, great, but you need to keep it that way. Yeah. So the lifestyle things are very important to start early enough. So regular exercise, stop smoking and vaping if you're doing that. Alcohol, keep it down. And on to our other subject, which we'll discuss, is keeping our weight down. Yeah.
Sian, what about the coronary artery calcium score? Is that something, that's something that a number of doctors also advise patients to have?
Yeah.
Something that I've done as well.
Yes.
So I can keep an eye on that and monitor it.
It's an excellent tool that we have available now. Absolutely excellent. It's not funded by Medicare.
No.
So there's an inequality in health there, because not everyone can access them. Yeah. And unfortunately, it's people who don't have the means who are a higher risk.
Yes. Yeah.
Yeah. But it is an excellent tool. And if you haven't had one and you're in your sort of 40s, 50s, especially if you've got a family history of heart disease, or you're known to have a high-ish cholesterol, or you're overweight, then it's probably a good baseline to get. But you need to do it at 5 yearly intervals. If it's normal, you can't say, oh, my arteries are fine. Well, yes, now, may not be forever. The other thing they pointed out is that women have slightly different changes to their coronary arteries. Men are the ones who are likely to have confined disease in a blood vessel. So it forms a plaque, which you'll likely detect on a calcium score. Women's disease is more spread out. So sometimes you won't see that on a calcium score. So as health professionals and as individuals, we can't say your calcium score is 0, therefore your discomfort, breathlessness, high heart rate is nothing to do with your heart. We've got to be careful that we don't make assumptions that could be incorrect. So what do you do as a patient? You have to say, okay, my calcium score is fine, but I'm still breathless. Yeah. I still feel funny or uncomfortable or dizzy when I'm walking uphill. I used to be able to run up hills, now I can't. Yeah, you've got to keep asking the question, okay, doc, it's my calcium score 0. Why am I still breathless then? Yeah. And keep looking, because women are different to men. It's not as simple. We're not simple creatures. We're complicated.
Yes. And as you said earlier, there's been a correlation between the decline in estrogen and the onset of coronary heart disease or coronary disease. Therefore, is the research saying that being on hormone therapy is actually helpful to reduce the likelihood of it occurring, or at least delaying the likelihood? Is that
exactly? Exactly. It is cardio protective, heart protective. It also helps keep our cholesterol levels in the right place, you know, with keeping our LDL, which is the cholesterol that clogs up the arteries, keeping that low and moving out of the circulation. So at the moment, there is no indication anywhere in the world for using hormone therapy for cardiovascular protection. At this lecture given by Professor, I think his name was Johnson, very good speaker from the UK, from the Brompton Hospital, which is a known cardiothoracic hospital, internationally renowned. He said, you know, find a reason to put them on hormones. If someone comes in and says, I've got no menopausal symptoms, but they're high risk cardiovascular disease, he will say, are you sure? Have you ever had a hot flush? And they'd say, maybe once. He said, you're right, you're in. You're having the hormones. So, you know, someone as eminent as that, who has been in this field for a long, long time, saying, no, we know it works. Estrogen works. And they've actually started doing trials, giving women who are in the process of having a heart attack estrogen to dilate their blood vessels.
Wow.
Yeah, it's in trials. Don't think that this is, you know, gold standard, but they're trialing it because they see that estrogen works for women, not for men. Yeah. So we have
so interesting.
We are unique in our physiology. We are different to men. Our human species is different, and we need to be seen as different and treated differently in these study trials and by pharmaceutical companies. I know it's difficult because it's very hard to get consent to do studies on women. There's a lot of concerns about, you know, especially infertile women, that you're going to cause fetal problems. So I understand it's not easy, but I think once people who are in this field start noticing the differences, when we need to listen and consider it when we're talking to women who have hormonal problems, who maybe are weighing up the risks and benefits, you know, because there's still a lot of fear around hormone treatment. But if you come in and you say, okay, I've got menopausal symptoms, but I really don't want to take hormone treatment because I'm terrified I'm going to get breast cancer. Very fine, I understand that. But if you're a ticking time bomb because you've got 3 relatives who've had a heart attack, and your cholesterol's high and your calcium score's low, but it's still there, would it not be, you know, reasonable to say, well, maybe you'll be getting an extra benefit if you did take hormones that may well prevent you having that heart attack when you're 60, 65. It's interesting.
It is interesting. And the length of time it takes for a study and research to come out and to be verified, and everyone's, you know, in agreement with the findings, that time period is so long. We don't have that time.
No.
For women. And we're so far behind the research game.
So far behind.
Out there for men. So, incidentally, you've got leading experts finding this in their day-to-day clinical work. Then it's something that we really do need to take stock of and go, yes, there is something in that.
Yes. And there was, I wish, I'm hopeless at remembering names, but she was talking about the kind of cutting edge stuff on cardiovascular health that is not just about women, but about men as well. And her research was definitely showing the benefits of estrogen to continue post-menopause. Yeah. So it's going to come. It's not there right now for women going through menopause right now. But I think as long as we stay engaged with women, medical we, and we give them the evidence and say, this is the pros and cons, risks and benefits, and for you, you know, because everyone's different, then a woman can make an informed choice as what's best for them, given their circumstances. And these risk calculation tools can be quite enlightening, and I use them all the time with patients and who are thinking, well, you know, I'm, you know, 49 and I'm fine and I'm fit, and you go, well, okay, let's put all this other stuff in and see what happens. Yeah.
Yep.
Helps that decision making, I think. But yeah, very interesting, that especially that disparity between what women fear of dying from and what they actually die from. Yeah.
Well, that's right. So we've got the high incidence of women dying from heart disease. Another big area where a number of women suffer incredibly through frailty, through osteoporosis, and then from falls, something that may kill some women. Can you talk about some of the research that's come out in the symposium that you went to?
Yes, the osteoporosis has always been a kind of difficult sell to patients, to be honest. You know, you're committing them to lifelong medications that are not without their risks, which were the bisphosphonates, brand name fosamax, and then the injections, Prolia, and there's an infusion called a cluster. So these were all that we had available to us to use for osteoporosis management. And it was basically, you could use them after you've had a fall, after you've had a fracture, or if you've actually got osteoporosis shown on your DEXA scan. So they were sort of like, oh, there's the horse bolting.
Yes.
What can we do to catch it?
Yeah. Yep.
And in that thinner bone range, there really wasn't an awful lot we could say to women apart from do some weight-bearing exercise and make sure you've got vitamin D and calcium, which are very, very important. But now we've got better at saying, this is the type of exercise you need to do. Yeah. It's people think, oh, I'm exercising, I'm going swimming. No, that's not building your bones.
Pilates. And I remember Professor Belinda Beck, who was on the podcast, explaining that they're great forms of exercise and will definitely help you, but not to strengthen your bones.
Exactly. You don't need a NARO or, going to see an exercise physiologist to get them some specific exercises. So what they have come out with, and this is now available and we can prescribe it for this reason, is using hormone treatment to strengthen bones. So when you get to, midlife, perimenopause, and you get your DEXA scan if you can afford it, because remember, the government doesn't pay until you're 70. So again, we get that disparity in health because not everyone can afford to get a DEXA scan. And I've had women who've been very surprised because they've always been active, they're sporty, get their DEXA scans, put them in osteopenia. Why could that be? Well, you have to look back in their history. Is there a family history? Did they have a time in their life where they were without periods, either through eating disorder or through over-exercising? They were an athlete, but, they lost their hormones in that time, so their bones weren't strengthening and building. So go back to the midlife woman who gets a DEXA scan and it's in that osteopenic, so bones are getting thinner. Yeah. We can use hormone treatment just for that, even if you don't have symptoms, to help build your bones and slow your rate of loss. We don't know what an individual woman's rate of loss is going to be unless you do serial DEXA scans and you can plot it and see how fast and rapidly they're losing bone. But now we can say, if you take hormones, it's going to flatten your graph. And if you do your bone strengthening exercise, you're probably even going to manage to build some bone, which is fantastic. So all those women.
Story. So yes, it is fantastic. It can be done.
Yeah, it can be done, and legitimately your GP is allowed to prescribe for that reason. Yeah. I mean, we still have to do the pros and cons, still have to do all the health check, shared decisions on that.
Yes.
Yeah. So that was really good. And a more clear cut, we go from using hormone treatment to using the bisphosphonates if you can tolerate them, and then later on the Prolia, and there were reasons given for this. So there's more of a guideline for GPs as to what to use and when and why, which was great. I took away from that. Yes, at last someone put it down.
Excellent. Yeah. And it's so interesting, isn't it? Because we've talked about the coronary artery scan that we can have to check for our heart and our heart health and looking at heart disease. Then we're looking at the DEXA scan, which can help guide us as to whether or not we're going to be osteopenic or have osteoporosis. All of these things could be, if they were done at a much earlier age, it would save so much more money, and people's lives aren't going to be affected as.
I know. But Medicare doesn't even fund it.
No, it doesn't. No, it comes out of my pocket.
Yeah, and I don't think health funds do either.
No.
So it seems very short-sighted, doesn't it?
Very much so.
If you look at what happens to our population as they age and what is the biggest money sink, it's people who need full-time care, often because they're immobile, often because of their problems with their bones through osteoporosis, but also loss of muscle mass, etc., and coronary artery events.
Yeah.
So anyway, politicians,
we'll get on our bandwagon. Last time you were on the podcast as well, Sian, you talked about GSM. What were some of the findings, or were there any findings that you on any of the sessions that you went to?
I think it was, reinforcing that women need to know about this, and the sooner you treat, the less likely you are to get problems. I mean, I see a lot of women in this arena, and so many of them already have significant vaginal shrinkage, that is impacting on their relationships and their own personal sex life, and it's preventable. It's hard to see. And then, you're playing catch up, you're trying to improve things for women, which you can do to a degree, but there's nothing like preventing it in the first place, is there?
Yeah.
And if you are someone who is reticent to try hormone therapy, vaginal treatment with estrogen has been given the tick, safe, doesn't cause breast cancer, doesn't cause endometrial cancer, can be safe and effectively used. Yeah, there's a caveat for people who've already had breast cancer that you need to discuss with your oncologist, which is fair enough. But a lot of oncologists now are saying that they're okay if a woman is significantly affected by GSM, that they will give the yes to using it. So I think it was just reinforcing. Ask every woman who comes to see you, doctor, are you having any problems with sex? Just put it out there, We don't, a lot of GPs still find it uncomfortable, but I think it's something that we need to ask, like we would take a blood pressure. I know I'm being a bit glib here, but, why not ask a woman who's going through menopause, what's happening down there? You're going to the loo all the time. Is it painful to have sex? Because a lot of women think, oh, yeah, well, it's a bit dry. Well, a bit dry can actually be the start of it. So get onto it sooner rather than later. Stops a lot of problems.
Yeah. Okay, so continuing on, what you shared in the last episode has basically been reinforced again, what you heard at the latest.
Yeah, reinforced there. Yeah.
One of the things also that, if you've got time just to talk about the evidence that's coming through now regarding testosterone. And
yes. This is a tricky one, and it seems to be causing a little bit of, I don't know whether it's a bit of conflict amongst the specialists or the experts, but the evidence is emerging. I mean, this is something that we heard time and time again through the lectures, is we don't have the evidence yet, it's emerging. I mean, fair enough. Studies haven't been done, we have to watch and wait and see. So if you look at the evidence that we have at the moment, it is still only seen to be working for women for loss of desire, and it doesn't work in all women. However, anecdotally, from my practice, I've definitely seen women get other benefits from using testosterone as far as well-being and brain fog. And Louise Newson, the UK advocate for hormones, has been doing her own research into this, and her research is emerging. Her numbers are improving and showing that, yes, it does help for, overall well-being of women, but it is not at the moment licensed or advocated for that reason alone. It needs to be with the loss of desire. Yeah.
Right. So can you just explain to the listeners what happens to the levels of testosterone in a woman as she's going through perimenopause and then postmenopause? What are our natural occurring testosterone?
Well, so, okay, one thing that came out from this is that the laboratory levels that GPs have access to are not sensitive enough to pick up the nuances from an individual patient. Yeah. So you can do a testosterone level in a woman and it comes in the normal range, but they've got no desire at all. So it's not really helpful. The only reason for doing the testosterone levels is to see what it's like before you start testosterone and see what it is in a month's time and 3 months' time to see if you're overshooting, if you're over treating. So that you need to do, that's in the guidelines. But there's no way of really measuring an individual woman's and saying, oh, well, you've got loss of desire because your testosterone level is this. It's not sensitive enough, the scales that we have. But what happens in our life is, yes, we have testosterone at this level, spiking mid-cycle. That's when we want to make babies. So it does fluctuate through the month, but we have good levels. And then as our ovaries shut down, so does our testosterone production. Yeah. Not all women have a loss of desire with that though, but some do. And then for some reason, it flips up again in our 70s.
Is that right?
Yeah. They don't know why.
Huh.
But in our 70s, we get a little uptick in our testosterone.
Oh.
But yeah,
I was skipping our stride when we're in our 70s then.
I don't know if it equates into that, but anyway, we'll. so the
needs
take
to be
home
researched again, Sian. That needs.
So I think it's testosterone. Where is it sat for us? It's sat for women who have loss of desire that is affecting their life and their relationship, and then it's a trial to see if it works for them. And if they also get the extra benefit of feeling more energetic and less brain fog, then that's an added bonus. But they can't say that will happen in all women.
Gotcha. Yeah. Okay.
So it's still a lot of exploration in the role of testosterone is in the pipeline. You just have to wait.
Yes.
It's emerging.
It's emerging. So watch this space. Watch this space. Now, I'm sure there's lots of other things that we can talk about with regards to what came out. I might have to ask you back for another interview.
Oh, well, if you'll have me,
happy to come. I know there's more things that when we discuss what we're going to be talking about and some of the findings and some of the things that you said were going to come out that you'd like to discuss. If we're going to get to these other areas today and mindful of your clinical time that you have with your patients coming up. So we'll talk about those going down the track. Okay, so let's move on to one of the most frustrating and triggering symptoms that women experience in the middle of life. That's weight gain, particularly around the belly area. I mean, our shape changes. It's not uncommon to have put on a couple of extra kilos on holidays or some other point in our lives, but for the majority of women, it was easier years ago to lose that weight. Just simply watch what you eat, do a bit more exercise, and that weight's gone. That doesn't seem to happen now. That same magic that we used to have on just easily losing those extra kilos has gone. So it feels like you can look at food the wrong way and you put on weight. You can be doing exercise, and in fact, some women increase exercise and the type of exercise, strength training, all of those sorts of things, and still they're putting on weight. So we know we're not going to have the same body as we did when we were younger. That's a given. We're not going to look like we were 20 or 30 when we're in our 50s and 60s and beyond. But now we're also dealing with a negative body image that can be coming along, as well as everything else that's going on. And it's hard for many, many women. So can you just explain what on earth is happening to our body and why might these things be happening?
Yes. One thing that is also really good to know, and this was also in the conference, is that there's so much research in this space, and now we have access to good information and good advice that we can give women. That it's not a matter of eat less, move more. It's more complex than that. But going back to your question, what is happening around midlife that makes us put on weight? With hormones, the drop in estrogen changes where our body deposits fat. Yeah. So our brains and physiology talk to each other, and they've come to the decision that once our hormones go, we better put some stores in. Yeah. So they put it all around our abdominal organs. So it goes into our livers, around our livers, a liver, around our gut in this thing called the omentum, and we get this belly fat. We also get more around our heart. Interestingly, yeah. So we know that when we get lower estrogen, that's what's happening. When we get that happening, our bodies don't respond to insulin as well. So we don't use up the sugar that we are eating, even if we are eating that sugar in good ways, in complex carbohydrates and vegetables, etc. The body just sees it as sugar and will then start depositing it in store form, which is fat. And then, our body then works against us by not responding to the insulin, which then makes us do things like crave more sugar. What a flawed system. Who designed this?
I don't know. I want a word with those people then. There are lots of women around the world that would like to have a sip.
It's just not fair, is it? So the more weight you put on, the more you shouldn't, the more you want chocolate, cake, chips. Your brain is telling you this is what you want, because for some reason your brain is thinking that you're going to enter a famine zone and you're going to need these extra stores. Bizarre. Anyway, it is what it is. So what happens is, on average, over perimenopause, menopause, a woman will gain 6 kilos by doing nothing different, really. But there are a few things that also play in here. We are usually around this time moving less incidentally. If we've had children, we're not running around after them as much. There's not that movement of, shopping, cooking, driving, helping them with sport. We're not moving as much. So if we're career women, we've moved in our career. So we're not moving as much. We're more sedentary. Our roles have changed. Our jobs have changed. Much more time in front of computers, less time out and about in the world. Yeah. So that has also plays into it. And the fact that we have ready, accessible, high calorie, low nutritional value food. So it's easy to grab extra calories that we don't need because we're on the move. We're sat by the computer, we're nibbling because we've got things that we can nibble on. So yeah, so all of those factors come into play as well. And then if you get crashing insomnia and hot sweats, you're feeling awful, are you motivated to do all the right things? Nope. You're going to want to sit and, you're unhappy. So you sit, and what do we do? A lot of us do when we're unhappy. We eat and we comfort eat, we food crave, and round the vicious circle goes. So you can actually put on more than the average 6 kilos, and before you know it, you put on 12, 10, more. And then you're in trouble because you're in that high BMI. Well, I hate that word, obese. Can't they come up with a new one? It's horrible. But for the sake of this conversation, you end up in the obese zone, and then you're scuppered, really, because it doesn't matter how hard you try with exercise and calorie control and eating the right things, your body is working against you. Your gut hormones, your brain working against you, and they will always get you back to your new set point. Yeah. So you were, say, 60 kilos for years and years and years. You hit menopause, all these other things happen. You gain 15 kilos. You're now in that BMI 29, 27. You're going to find it almost impossible to lose weight without help. Yeah.
So what sort of help are you talking about, or are they suggesting? Like what's...
Well, obviously you need to do the lifestyle things. You need to move. You need to, stop snacking. Yeah, that's one of the things we do. We eat when we're not hungry. Those are the things. The lifestyle is still pivotal. If you're struggling to make those lifestyle changes, then you obviously are going to need some support through a dietitian. But things like very low calorie diets, so using shake supplements to really reduce your calorie intake can be helpful. Yeah. Going to see exercise physiologists to build you an exercise program that will advance as you advance. A lot of people don't want to go to the gyms, especially if they got a bit of body, hatred going on. They don't want to go and pump iron with all the beautiful things. So an exercise physiologist is trained. They're trained to help people who are rehabilitating, who need to start slowly and build confidence and work with you to get you moving and help you on that journey to getting to your target weight. So those are the sort of cornerstones, and they need a lot of time and effort and support. Again, you're going to get that disparity in health because it's expensive to see dietitians and exercise physiologists. Yeah. But if you do all that, say in 3 or 4 months, you've not lost an awful lot of weight, you lost less than 3% or 5% of your original starting weight, then there are medications now, that we can use as an adjunct to help you get to that losing 10 to 15% or more. Yeah, because we've got to remember that it's not just about how we look and feel, it's about our health as well. Yeah, it's if we're overweight in that high risk obese range, then we've got increased risk of cancers, heart disease, diabetes, musculoskeletal joint problems, etc. So it's not just about aesthetic, it's about health. And one of the things that was, pointed out and reinforced is being obese. It's a chronic disease. So people need help.
Yes.
They need to be treated appropriately and consistently.
Yeah.
And with compassion. Yeah.
And also an individualized approach, because every woman would be coming through your doors or another doctor's doors or whoever they see with completely different, some similarities, but different background stories, different health needs, different, what could be causing it could be completely different. So there is no one size fits all program that is going to suit every single woman. It's going to have to be really discussed at length with the help of other people around you.
Yeah, it's a team approach. Once you get into that, risky BMI, it's a team approach. For those of us who are, going up a dress size, those who are sort of maybe a size 8, 10 going into a 12, 14, we don't want it to get out of hand. We want to not have to buy a new wardrobe. What do we do? Well, then we need to really look at what we're eating, how we're eating, empty calories in drinks, and what type of exercise we're doing. Yeah, because obviously that very low calorie diet, medication use, medications such as semaglutide, Ozempic, Wegovy, they're for people who've got health risks associated with their weight gain. Yeah, those who are more wanting to stay fit and trim, they've noticed that 6 kilos, well, then you have to do something differently to stop it advancing. But you may have to accept that you are going to be 5 or 6 kilos bigger than you were when you were in your 30s.
What about those women, I'm just playing devil's advocate as well, whose weight may increase because the type of exercise they're doing is different. So rather than spending a lot of time or as much time on cardio, perhaps they're doing more heavy lifting, strength training, so their muscles are bigger. Like, is that something that comes into play as well? Is that the weight of muscle that they're gaining is contributing to some? I'm saying, definitely not saying all, but can that also be part of weight increase?
Yes. So if you're at that kind of stage and you're wondering, measure your waist, because that's where if we've got fat around our waists, that's where we're going to be having the health risks. So ideal for a woman is maximum 80 centimeters. So that's a good way of working out where your health risk is from your weight.
Is that worked out again? Is that worked out on, if our body shape changes, that 80 centimeters, is that worked out on a younger woman and that's the ideal for a younger woman? Or is that women over the average of all the stages of life? Like, it's interesting where the numbers
come from. Yeah. I think that's based on diabetes risk and cardiovascular risk research.
Right.
Yeah. So yeah, you have to take it into individual context.
Yes.
Yeah. So if you've got a woman who's got an 85 centimeter waist, but their cholesterol and everything's fine, their blood pressure's fine, they've got, they move all the time, their diet's great. Well, you're not really going to bang on about them losing that 5 centimeters. So again, it's looking at that holistically. But if your question was if someone notices the scales going up and they think, oh, am I still putting on fat? Well, that may be one way of measuring it. Measure your waist and your body. Exercise physiologists are really good at telling you, because they've got these fancy scales that can actually tell you how much of your weight is body fat and how much is lean muscle mass.
Yes.
So you can always go along and see an exercise physiologist if you game. I've stood on one of those scales. I didn't like it.
So what is also the difference between the subcutaneous fat and the visceral fat? I know you said the visceral fat is around the organs.
Yeah.
Is it the subcutaneous fat, that the handful that you can get around your tummy and just do, oh God, if I can only, do a jiggle, get rid of this. Is that what? Yes. Well, that is a different way of losing.
Yeah, no. I mean, there's a certain amount that we get, which is just under the skin. And that comes from, aging and, just having babies and that kind of thing. But when you get that firmer, rounded tummy, then the fat is deeper.
Right.
Yeah, that's where it's deeper in your tummy. And then it's more likely to be around your visceral organs.
Yes.
But any fat is going to stop your insulin working. You're going to get that insulin resistance. It's not going to get into, you're using your sugar up effectively, and your body, doing that naughty thing about wanting to store it for some reason.
It can be so triggering for women, and particularly because we've come through a generation where the diet culture was entrenched from such a young age, and the fact that this is happening along with so many other transitions at this time of life can be really confronting women as well, can't it?
Yeah, it is. But it is. It's like a perfect storm, isn't it?
It is. But
and at the same time, your kids are leaving home, so you're suffering from empty nest. Your parents are falling off the perch. It's if you really think about it, it's quite depressing, isn't it? You're just like, what?
The good, the bad, and the ugly. That's the ugly side. What role, Sian, of cortisol? Does that play a role?
I wouldn't say that I'm any expert in the conversation around cortisol. I know it's a lot talked about by integrated GPs or alternative practitioners. Okay. Stress is not good for us. Yeah. It does impact on our lives and how we eat, how we can move, etc. And cortisol is a stress hormone. Most of us manage to keep our cortisol levels in quite a a narrow range, and it's very rare that we have pathological cortisol levels that cause us problems. So I must say I don't have an awful lot of knowledge in this space of cortisol and what it does for women putting on weight. I'm sure it does have a place. It wasn't discussed in any of the lectures I've been to. So obviously, unless it's pathological, outside of the normal range, I don't think there's been any evidence that this is something that women need to get too focused on or spend a lot of money chasing with alternative practitioners. So I think it's enough to say that stress isn't good for us in many, many ways. And yes, will not help us lose weight, because you're not likely to be motivated to move if you're under a lot of stress, or alter what you're eating if you're under a lot of stress.
Yes.
But I must say my knowledge in this is not extensive. Yeah.
Now, I'm very mindful of time, because you've got a patient that's going to be coming through your doors.
Yes.
A matter of minutes. So our listener questions are going to have to be held again over to another episode. And my apologies to all the lovely ladies who are still waiting for their questions to be answered. But we did have some technical issues.
We did. That's my fault.
To get us going.
I am
made it a
rubbish.
little bit late in recording.
Rubbish at tech. There was one, you did actually send me one of the questions, and I will just give you a quick one. There was someone who said that she was very progesterone sensitive. And
yes, that was from Lynn. She said, I'm progesterone intolerant. It causes pain, dermatitis, hence no HRT. What other options are there for me?
Yeah, go and ask your GP about a medication called Tibolone, brand name Livior, which is a prodrug. You take it into the body, and the body turns it into estrogen and progesterone in the cells. That may be worth considering if you haven't already. Go and have a chat with your GP and see if you'd be a good candidate for that. So yeah, that is something that you could consider. So I just remembered her and thought, okay.
Excellent.
Let's get her sorted.
Lynn, there's a few other ladies who are missed out. But we'd love to have you back on again to talk about some of the other really interesting things that are coming out with research now on how we can look after health in the middle of life and beyond, and also the listener questions. So thank you, Dr. Sian, for coming on and spending this incredible time with us and sharing your knowledge. It's very much appreciated. Thank you so much, and thank you, Jo, for your patience with me and the tech. You're welcome. You're very kind. Thanks, John. Now, this is the last episode for the year, and I'd like to take the opportunity to thank you so much for listening and supporting my podcast throughout the year. I hope you've been able to learn something that helps you to live, be, and feel more empowered so that you can redefine your own midlife. It takes dedication, it takes time, effort, and money for me to bring these episodes to you each week. And it's definitely a labor of love, though. As a little sign of your appreciation, it would mean the world if you could just take a minute of your time to rate and review this podcast on whatever platform you listen to. Also, share this episode with one of your favorites in the world. Now, this helps the podcast reach more amazing women like yourself. I hope you all have a very happy and a very safe festive season. Take care, and I'm going to be back early in the new year with more amazing episodes featuring some incredible guest experts and fabulous everyday women doing incredible things in the world.